Welcome to this edition of Grand Rounds, exclusively produced by Pituitary World News. We are pleased to have Dr. John Carmichael, a distinguished expert in pituitary medicine from the University of Southern California, joining us today. He will present his thoughts on the controversies in diagnosis and treatment of acromegaly.
So thanks for the introduction, Louis, and I want to thank Dr. Blevins, Dr. Comor, and Dr. Aghi for the opportunity to come and speak. Controversies in the management of acromegaly is actually one of my favorite topics, and I haven't really given a talk devoted to those controversies. I haven't approached acromegaly from the aspect of, what are the controversies in management? And so this is just really a lot of fun for me to go back through both things that I've encountered in my career in terms of the approach toward the care of patients with acromegaly and those things that have brought controversy. And what I like to think of is it's more about sort of the clinical dilemmas that we face. And those clinical dilemmas then lead to controversy because there are different ways of tackling those clinical dilemmas. So you'll see in my talk here, we'll talk about some things that came to be very controversial, but we'll also talk a lot about some of the clinical dilemmas that we face as we take care of patients with acromegaly. These are my disclosures. And just an overview of the talk. One quick caveat. So I'm going to be reviewing things in terms of the controversies that we face. This is by no means meant to be an overview of every aspect of the management or diagnosis of acromegaly. So we're going to sort of cherry pick some things. We're going to pull some things from the management of acromegaly, and we're going to deep dive into some of the conflicts that we face when we're treating patients, and some of the things that have led to controversies. So it's not so much a comprehensive review of things. We won't touch on all of the medications or all of the things that we deal with acromegaly, but really some of the things that highlight some of the controversies that we face. There are controversies in every aspect of care. So we will be talking about everything from diagnosis to the management and long-term surveillance of patients with acromegaly. And fortunately, there's just so much for us to talk about in terms of the controversies. Key things that come up when we think about controversies in acromegaly come down to things like diagnostic testing. And they come back to things like the sequence of treatment. What time do we do what we need to do in order to take the best care of the patients? And then in terms of thinking about medications, how do we select which medication is the appropriate medication for the patient? And what things have guided us in terms of, and informed us in terms of how we select those medications. And then we'll talk a little bit at the end about comorbidities. I didn't go into so much about quality of life, but all of these things feed into the quality of life of acromegaly. We know that one of the things that is kind of controversial is, despite all the things that we do and despite the control that we get for patients in terms of their disease state, they still suffer from an impaired quality of life. So no matter what we do with patients with acromegaly, they're left with a quality of life that does not match up to even those patients with non-functioning pituitary tumors that we treat. So a real devastating disease that affects patients for the rest of their lives. Just as an overview, I'm going to, in the next two slides, simplify the diagnosis and management of acromegaly so we have kind of a framework to work with. And the diagnosis of acromegaly is actually quite straightforward. The toughest thing that we face in diagnosing somebody with acromegaly is thinking, does this patient have acromegaly? And there are accounts of endocrinologists that have been treating patients for years where acromegaly slowly develops just right in front of their noses. And it takes sort of putting all those things together that comprise the syndrome of acromegaly in order for somebody to think, well, I think there might be a growth hormone problem underlying all of the things that are going on with this patient. And then once you have that thought, making the diagnosis actually pretty straightforward. Now we'll go into some of the controversies that surround some of this stuff, but checking an IGF-1, making sure that that somebody either has a normal or elevated IGF-1 is a fairly straightforward thing. You don't need to do dynamic testing like we do in a lot of other situations with pituitary disease. Send someone to the lab, check an IGF-1, excellent screening test. The oral glucose tolerance test, where somebody's given a sweet cola and they drink that, and we check growth hormone and glucose after the glucose load, that has been helpful and has been described since the 1960s in terms of its effect on growth hormone secretion, and it has been helpful in determining whether or not somebody has acromegaly. It has basically kind of fallen to the wayside because IGF-1 has become a better test in terms of making the diagnosis of acromegaly. It's a little laborious and, again, a dynamic test, so we don't do it as often. And you'll see some of the problems that we've encountered with the use of OGTT during my talk. After we've done the biochemical testing and we've established that somebody has an elevation of growth hormone, that's when to get the pituitary MRI, because the overwhelming majority of patients are going to have pituitary tumors that are causing that growth hormone elevation. There are rare exceptions to that, where you have ectopic sources of GHRH, even more rare ectopic sources of GH, but that is your diagnostic algorithm right there. And this figure demonstrates what we do in terms of managing that patient once we've made the diagnosis. And again, a very oversimplified approach to this. Once we have a patient, surgery is first line for most of those patients. We'll take them through pituitary surgery. If they're put into remission, then we observe for any recurrence. And if we don't experience remission with that first surgery, typically what we resort to then is medical therapy for those with persistent disease. And then from that point on, you can use radiation for some patients, but also because of the effectiveness of these medications, in many cases we don't need to use radiation, but it is used and variably used in different centers depending on both the patient's course and the physician's reliance on radiation for disease control. This, by the way, comes from now, I believe it's maybe 10 years old. This figure comes from one of our clinical practice guidelines. And we'll talk next about clinical practice guidelines and consensus statements. And this one I think is good. I think it's up for, there should be something newer coming that incorporates more of the medications. I want to point out one quick thing here. And this was one of the first times where we saw basically an equivocal use of somatostatin receptor ligands, dopamine agonists, and pegvisomant. It wasn't very clear at the time, but they were trying to say that really these three have equal footing in terms of your choice. I believe the text said that. It wasn't really clear because all of the things that came before that really had a sequence of treatment, and we'll talk a little bit about how the consensus statements and some of the clinical practice guidelines really emphasize the use of other medications, but it also has to do with when those medications were developed and the early use of somatostatin receptor ligands really taking over the treatment over the dopamine agonists, and then eventually growth hormone receptor blockade being available to add to that armamentarium. So consensus statements and guidelines. One of the things about sort of acromegaly and the controversies embedded in it is that you'd think that with all of this disagreement that people would be able to form some sort of consensus. It has taken them 15 meetings of the acromegaly consensus group. There have been many other meetings of other societies to develop clinical practice guidelines. And so clearly there's a lot of controversy because we need so many meetings. And I say this sort of tongue-in-cheek. They go to these exotic locations every year, and they have these big meetings where a group of acromegaly experts present data and then try to come to some consensus. And as we'll see, these consensus statements have evolved over time to include new data. They've evolved over time to improve our understanding of the best course of treatment for patients, but they also generate controversy. And you'll see that when the group of clinicians and scientists get together and make their statements about what they think is the best course of action, that there will be disagreements about that, and that generates controversy itself. One of the first meetings was held in Italy, in Cortina. And this meeting, actually, it's the first consensus workshop group meeting, but some of the founding members had met earlier and created a clinical practice guideline. That was published in 1998 in the JCNM with about 5 people who are really the most sort of prominent people in the acromegaly world. You've got Ann Klebansky, Ariel Barkan, Shlomo Melmed, David Kleinberg, who were all sort of the first, and Andrea Giustina, some of the first people who got together to talk about formulating these consensus statements for acromegaly. At this meeting, and one of the things that we'll talk about next is sort of the criteria for diagnosis and what constitutes disease abnormality and normal responses to some of our testing. It was here where growth hormone of less than 1 was offered as a criteria for disease control, and that those growth hormone levels that were above 1 were thought to be inadequately controlled. And then there were levels that were poorly controlled with elevated IGF-1 and clinical activity. Now, a lot of this data does not have a clear foundation in terms of where it comes from. Later on, we saw that using growth hormone of less than 1 and normal IGF-1 with data that came out of New Zealand, that we were able to approximate a normal morbidity and mortality for those patients with acromegaly the closer we got to a growth hormone of 1 and normal IGF-1. But that actually came after these criteria. And so while there may be some thought that these were good criteria that implied that the patients were normalized or at diagnosis were normal compared to having patients with elevations of IGF-1, there's not a clear aspect of where these disease states or these cutoffs came from. And so one of the first things that came after this consensus statement was an editorial about whether or not this truly was a meeting that generated a consensus on the criteria for cure. And this disagreement and this idea that we had not quite reached consensus would then kind of go on in conversations for the next 10 years. We knew at the time that because of early clinical data that things like age, sex, and weight all contributed to differences in growth hormone and differences in IGF-1. But these things were not captured by consensus statements. And sometimes when we have things that are nuanced like this, we lose those when we try to make a statement that's general enough for people to use as a diagnostic criteria. Some of the early things that didn't jive with this cutoff point of 1 were uses of highly sensitive immunoradiometric assays. And there were publications that described normal patients who had values of less than 0.13, clearly much lower than the 1.0 cutoff point that was offered by the consensus. And those patients above 0.13 had active disease. And so we see publications looking at things that were termed micromegaly, where you had elevation of IGF-1, but growth hormones that suppressed below 1 with an OGTT. You had patients who were in remission with normal IGF-1, yet their growth hormones didn't quite get down to that lower level below 1. And we'll come to or below 0.13. We'll come to some of those studies as we go through the talk here. So as these consensus statements and as our use of the diagnostic criteria evolved, there was considerable debate regarding how these things were to be properly used. One of the things that became clear was that growth hormone and IGF-1 weren't always equally useful in all of the disease treatments that we had. Big Visimont came along. We couldn't measure growth hormone anymore. We had to rely on IGF-1 only. Use of the somatostatin receptor ligands. How did that affect OGTT? One of the things that I wrote about when I was at Cedars was that the somatostatin receptor ligands made the OGTT not useful at all, and in fact can be misleading and lead to discordant values of growth hormone and IGF-1. And how to deal with that discordance was also something that begat a lot of controversy because it was difficult to tell what to do with somebody who had normal IGF-1 and elevation of growth hormone, or vice versa, elevation of IGF-1 and a normal growth hormone. Still, things like sex, age, and BMI didn't quite filter into our concept of what normal was for some of the testing that we did. And there was a high degree of variability among assays. This figure comes from a publication that I worked on yesterday. Dr. Blevins talked about IGF-1 as a predictor of, or a risk factor for cancer. And when I was a fellow, we worked on this study looking at IGF-1 in healthy elderly individuals between the ages of 50 and 90. And as part of our protocol to look at their growth hormone responses to growth hormone stimulation, we got IGF-1 levels on 2 occasions, 2 weeks apart, and we saw a high degree of variability in those patients. Now, these were not acromegalic patients. They were not treated. There were no instructions given to them other than just a fasting IGF-1. And here we saw up to about 30% variation in that IGF-1 result within the same patient. Most of these within 20%, but there were some really striking differences between these IGF-1s, and about 40% of those patients changed from an upper quartile or a lower quartile to a different quartile. So trying to say that somebody's quartile of IGF-1 has a risk factor for cancer, I think, is sort of pointless, because it depends on what day you check the IGF-1. This study, I think, is one of the things that I find most disconcerting when I'm trying to take care of patients with acromegaly. Now, this is a little older. I don't think it's been replicated since, but what they did was they took a growth hormone sample, and as part of their quality assessment in various labs in the UK, they took a sample of growth hormone and a sample of IGF-1. They sent it out to the labs, and this was from somebody with active acromegaly who had a nadir response to OGTT, and the instructions were, okay, this is a person with acromegaly. We want to find out if they've got active disease or not. Same for the IGF-1, sent to 23 centers instead of 104. And here we have the IGF-1 results. And if you look at the columns, so this is the same assay at different sites. And along the y-axis, we have the different assays that were employed in the UK at the time. And we see a 2.5-fold variation in the same sample with sometimes the same assay done at different centers. And so you can send a sample to a place and you can get a very different result depending on where you're sending that sample. And it comes down to assay. It comes down to how good that lab is at preparing that sample for the assay. IGF-1 requires a protein extraction step. And this is the thing I think that really affects the veracity of that sample, is that there's a lot of steps that are required for us to get an IGF-1 value at the end of the assay. And some places are better than others at doing it. The Nichols Advantage assay at the time was probably the most reliable assay and one of the widely used assays at its time. But here you see a huge variation in how labs are employing that assay and getting different results. We saw the same thing with growth hormone. High degree of variation, and I highlight here the Nichols Advantage and the DPC Imulite because along the way, Quest decided that they no longer were using the Advantage assay and switched over to DPC Imulite 2000. But in order for you to know what you're getting from your lab when you send the growth hormone out, they have to tell you what assay they're using. And they don't always tell you. And they won't tell you that they're no longer using an assay and they've switched to another assay. So one of the things you have to do if you're treating patients with acromegaly is know what the lab is doing. Is the lab using, the same assay that they were 2 years ago when you checked an IGF-1 or a growth hormone in those patients? Because that is going to be helpful in telling you whether or not you're looking at the same kind of result. But these lines here are used for the different cutoff points that were put up by the consensus statements. And here you can see that depending on what lab you send your growth hormone result to after you do an OGTT, you can have a normal or an abnormal result depending on what assay they're using. So difficult because there's a lot of uncertainty, right? And so having to deal with that uncertainty is often one of the biggest challenges. And I find it kind of fun, but when I give this talk, a lot of people are like, well, I don't like the fact that I can't use this test. And in fact, one of the things that I think most endocrinologists like is that we can test something and we can get a result and we can do something with that result. We know that if it's elevated, we can suppress it. If it's low, we can replace it. And this kind of throws a wrench in that paradigm. So it is difficult thinking about that uncertainty. One step further, this is a study looking at patients with controlled acromegaly or uncontrolled subjects and healthy subjects. And they performed OGTTs and across time measured the growth hormone with 3 different assays. And here we see how growth hormone assay choice affects our results with the OGTT. We see a bias in certain growth hormone assays. You see that they're very tightly correlated. So if you do your testing and say, well, if I do this and everything, yes, this one's high and that one's high and that. So they're tightly correlated, but you see the positive bias the further that line drifts from that diagonal. And so what's the answer? What do we do with this information? And how do we think about growth hormone and IGF-1 testing in patients when we've got consensus statements telling us that it should be 0.4 or it should be 1.0? One thing I really like about this study is that it gave us good data for a few assays in terms of what the cutoff point ought to be. And anytime you have individual data for an assay, you should use it. You shouldn't use the consensus statement. You should use what's available to you that's specific for that assay. So if we are using things like the Imulite, which was at the time a very prominently used assay in a variety of different labs, Quest, LabCorp, for growth hormone, we should be using a cutoff point of 1. But at the same time, the consensus statements are out there telling us, you know what, 0.4 should be our cutoff. But that doesn't fit with some of these studies that show that that actually doesn't quite work with the reality of using these assays in studies looking for that cutoff point. So then they decided, I think they went back to Cortina even, but they decided that there was a revision needed for these consensus of cure. But what you see here is that they're not saying anything about assay-specific cutoff points. What they did was they tried to say still that 0.4 was the cutoff that should be employed for whether or not somebody had active disease or non-active disease as a measure of surgical outcome. And that discrepant results, things where your IGF-1 and your growth hormone don't match, you could do multiple GH sampling. Well, that's impractical because we've already tried doing the OGTT over 2 hours. To do a 5-hour sampling of growth hormone may or may not be helpful in determining whether or not somebody has something that matches with their IGF-1. But it's also a laborious thing to do, and it kind of jams up your clinic for the day, and it's impractical for the patient as well. There were some changes in some of these definitions in terms of inadequately controlled or poorly controlled to just active or controlled. They simplified some things, and there was this revision. But that 0.4 number, I think, is something that nobody really knew where it came from. This is data coming from Pam Freda's group that looked at normal IGF-1 patients post-surgically with elevation of growth hormone above their assay, and with growth hormones that were below their assay. And what they did was they saw that it's separated into 2 groups. It makes sense that those with the lowest growth hormones after OGTT have the lowest chance of recurrence. And sure enough, those patients with a very low growth hormone after OGTT did not experience recurrence during their 5 years of follow-up. But those with growth hormones above that threshold, which is a low threshold, did have about a 25% recurrence rate as they followed them over the next 5 years. Now, the 0.4 number ostensibly comes from this data, but their cutoff point was 0.13, and it's not a commercially available assay. It's an assay that's only available to them. So in order to sort of accommodate everybody else in the world, they said, well, we'll just sort of double it and make room for a little bit of variability, and 0.4 will be our cutoff point. It didn't make a lot of sense to me at the time. I think that it sort of led to a little bit more controversy because even nowadays we still see publications that cite 1 as the cutoff point, 0.4 as the cutoff point. But let's fast forward to the most recent consensus, and that actually makes everything that I've just talked about somewhat obsolete, which is they said, well, all this talk about the OGTT, we're going to de-emphasize the use of it. We're going to only need it in equivocal cases. We're going to get rid of the cutoff points that we had, and we're going to actually talk about BMI cutoff points if you do use it, but it's really de-emphasized. And so now to make the diagnosis of acromegaly, what do we need? We need a clinical suspicion and an IGF-1. And here's another point of controversy, and that is this 1.3 times the upper limit of normal. So I'm not exactly sure where this comes from. I did show you that we did this study looking at normal patients in IGF-1, and there was up to about a 30% variation. So are we trying to capture that with the 1.3 times the upper limit of normal, or are we trying to say that, well, if it's just above the upper limit of normal, that might be just with the coefficient of variation with the assay, but 1.3 for sure, now they've got it. So I don't know exactly what this is, but it comes up in almost every clinical trial that's done to look at IGF-1 and response rates to medications, and then goes to the FDA for the approval of these medications. So a margin above normal for IGF-1 has persisted within our literature. All right, so if assays bore you, I'm sorry, but we'll move on. But it is one of the things that I found to be very interesting and something that I really was passionate about when I was first, in this field of pituitary medicine. Now we'll talk about surgical and medical treatment of acromegaly and transition to some of the controversies we see here. So just up front, in terms of what constitutes a controversy, is the establishment of who should be taking care of our patients. And it's controversial not so much in the sense that we think that people who do excellent work should be taking care of the patients. They're probably the best at it. It makes intuitive sense, right? But I think when we say, okay, we want to establish centers of excellence, it comes down to the real sort of issues of, well, who's going to establish those criteria, and who's going to say that some centers meet those criteria and don't meet those criteria? Who's going to certify that? And that's where the controversy comes. You can be an excellent center. You can have excellent physicians in your center. You may not do all of the things that they say constitute a center of excellence. But that doesn't necessarily mean that you're any worse at taking care of a patient with acromegaly than somebody else. But there are certain things that I think are important, and much of that comes down to patient volume. If we look down at the surgeries for pituitary centers of excellence, there needed to be a number. And the last line here has 50 per year as a threshold that they think constitutes an experience level that implies better outcomes. Now, I would say that 50 per year is probably still low enough that there may not be an adequate level of expertise. If somebody does, 1,000 and then gets into a part of their career where they're doing 1 a week, maybe that person probably does have, outstanding experience and good outcomes. But they had to pick a number. And this, I think, is another point of controversy. And I think that, here at UCSF, you've got a number of surgeons and a very busy center, obviously a center of excellence. But if you go, 100 miles, to the east, and you say, okay, well, is there somebody there who's doing 50 per year, and do they have the adequate expertise? They might get a little concerned that they're not fitting in with sort of that criteria of expertise. And so anytime you kind of exclude people from a category that they want to be in, you're going to generate controversy. And I still think that we do need to adhere to this idea of clinical expertise and centers of excellence, but it does become difficulty when there's no really verified certifying agency, and there's sort of a nebulous criteria. But the principle, I think we can all agree on. The more experience you have, the better the outcomes, the more your patients will be comfortable with your approach. One of the things that feeds into the idea of surgical expertise is the fact that the surgical experts are out there publishing. And the thing that's not on this slide are the publications, or there aren't publications of people who don't have high volume centers. And so this slide I've kind of put together over the years as more series get published. We see a very high rate of remission in patients, especially in the microadenomas. We see centers of excellence who have outstanding outcomes, and you see here too that the macroadenomas don't have as much of a high percentage of remission. And this makes sense, and we know this from other series, that the patients who do well in terms of their remission, the smaller the tumors, the more encapsulated those tumors are in the cell, the higher likelihood of remission. But what we don't know is what's happening in the rest of the world or the rest of the country. And there have been papers that have been published that do surveys that ask, so how many pituitary surgeries are you doing? And shockingly, I think the majority of pituitary surgeries still in this country are done by surgeons who do less than 8 per year. And so while we like to think that patients are seeking out pituitary excellence and coming to pituitary centers, there are still a lot of people who don't have access to those centers and are being operated on people who don't have the same volume and outcomes, most likely. And it matters with our hormonally active tumors, and it matters with the big tumors with those outcomes. One of the things that has generated controversy is, and coming to sort of the sequence of treatment, is pre-surgical treatment with medication to improve outcome. We know that somatostatin receptor ligands have an effect of tumor shrinkage on patients with acromegaly. It makes sense that if we then think, okay, well, smaller tumors do better in terms of remission, let's shrink the tumor down. Let's send them to the surgeon, and let's see if we get a better outcome in terms of that patient's chances of remission. Now, there was some controversy here because only one center had a statistically significant difference between their treated and their untreated patients. And we'll come back to this group because they published a study later on regarding their clinical experience in terms of better outcomes. But for the most part, in retrospective series, we did not see an improvement in outcome with patients who were treated with medicine prior to surgery. And this is retrospective data, and then there were 2 studies that were prospective. It says recent, it's now getting a little old, but they were prospective randomized trials. They were performed in China. There was 4 months of lanreotide, 3 months of octreotide, and then what they saw was that there was tumor shrinkage and improved postoperative cure rates with the pretreated versus the untreated. Now, the difficulty here was that there was probably an influence of the medication in their assessments of remission at the time that they did it after the surgery. These drugs have a long half-life, they've got a long tail of efficacy, and there's probably a long duration of suppression of medications after they're stopped. When we looked at 12 months in one study, there was no difference compared to those that weren't treated. And the other study had no long-term follow-up. So we still conclude that pretreatment doesn't afford us a long-term benefit in terms of remission. And there may be some benefits. The patients may be less symptomatic. They may actually improve with medication. But in terms of long-standing remission, we do not adopt an approach of pretreatment because the long-term effect is not persistent. Now here we go back to Dr. Calau's group in Italy, and what she did was retrospectively report on their group's approach toward their patients with acromegaly. If you look at the methods of their studies, it's like every patient that comes to their clinic gets put into their clinical protocol, which is pre-treatment because they have to wait a long time for the surgery, and then they get surgery, and then they're either in remission or then they go back on medication. And this figure shows that as they go along with their treatment, if you look within disease, the tumor size categories, as they get treated, the better off they are. So this, again, this sequence of treatment, pre-treatment, surgery, post-surgical assessment and then retreatment tends to afford us the best chances of remission. But this, again, was a clinical protocol and was written up in retrospect. I was part of a clinical trial that was done by Dr. Kleinberg. It was a multi-center clinical trial, though, with several centers in the US. And it was the first of its kind to randomize patients prospectively to either pre-surgical medical therapy versus surgical therapy. And it was a 2-to-1 study where we had twice the patients in the surgical arm because we knew that patients were going to go in remission after surgery, but we wanted to see if the debulking of the tumor offered better responsiveness to the medication. And what we saw here was that there clearly was an improvement in patients, most often with the sequence of patients receiving medication and then doing surgery, and then even better responses with medication after surgery. So this was sort of the closing chapter of our idea of primary medical therapy for patients with acromegaly. We saw that primary medical therapy, while appropriate for some patients, and especially those who weren't good surgical candidates, really did not do as good a job in terms of getting people to remission in a short time frame of 3 months. But it really helped us think, okay, what is the sequence that we need to do? We don't need to pre-treat. We need to go to surgery, and we need to then assess for a cure and then treat afterward. All right, this figure here, just an example of medical therapy and our treatment algorithms and how to approach patients. We know that surgeries are effective on the whole, probably around 65% of the time. We know that we can use radiation for aggressive cases, but we still need to use medication while radiation does its effects on the growth hormone secretion. And so medical therapy is a necessity for many, many patients that we treat. And how we choose our medications and how we assess the effectiveness of these has prompted a lot of controversy over the years. I'm going to start off with cabergoline and talk about this real quickly here, mostly because it still persists and we still use it. I use it sometimes too, but one of the things that early on in the publications that led to our use of it was the fact that if somebody had co-secretion of prolactin and growth hormone, it was thought that this was a good candidate for cabergoline or a better candidate for cabergoline than somebody who didn't have co-secretion. And this came from Roger Abb's study where he saw that 36 patients who were tested, that there was IGF-1 control in our co-secreting group compared to 35% in growth hormone only. That data has actually never been replicated. And if we look in a larger study here, meta-analysis of cabergoline use, really the thing that comes out from this, and it was within Dr. Abb's study as well, is that it's really only appropriate for patients with mild disease. Co-secretion doesn't afford us a better outcome with cabergoline use, but if the IGF-1 is just a little bit above the upper limit of normal, the better off your success rate is with the use of cabergoline. So we really only need to use this and reserve this for patients with mild disease. So a little bit of controversy because of the co-secretion, a little bit of controversy because it persists in our use despite other medications that are much more highly effective. But now we get into the controversies regarding effectiveness of medications, all right? Now, somatostatin analog therapy has for a long time been the sort of mainstay of therapy for patients with acromegaly in terms of medications. Octreotide came along, it was selective for SSTR2 and had a very good effect on growth hormone secretion and tumor control and tumor shrinkage. So we have a lot of really good data here. This is a meta-analysis from Dr. Freda's group. They looked at it was about the first 10 years or so of experience of growth hormone suppression from somatostatin receptor ligands. At the time, octreotide and lanreotide were used, lanreotide primarily in Europe, and so she took all of the publications and looked at the efficacy rate of these. And At the time, the things that stood out here was that we saw a 50 to 60% response rate, or in lanreotide slightly lower, but this was an earlier formulation of the 2-week preparation. The preparation that we have now is different. Probably behaves a lot more like octreotide LAR in terms of efficacy. But I want to draw your attention to the 50s and the 60s in the upper box here. You see that there are some that are unselected and pre-selected. Here is one of the biggest controversies in our use of somatostatin receptor ligands, is that the early studies looking at the use of somatostatin receptor ligands in acromegaly included patients who responded to a dose of the octreotide with a drop in their growth hormone. If you did that, you got into the study. If you didn't do that, you were excluded from the study. So anybody who takes a look at that from the bird's eye view is like, well, you're setting yourself up for success if you're only going to include people whose growth hormone drops to a single dose of octreotide. So that's not fair to say that that's your response rate, right? But the truth is that even in unselected patients, in studies where they didn't give that dose of growth hormone, you had comparable rates of control, all right? So we all thought for a while, okay, somatostatin receptor ligands are great. They're going to work in probably 50%, 60% of the time, and I'm going to use these on my patients. And that actually matched clinically with our experience. I think most patients that we treated ended up getting disease control. And there were a few that were resistant and a few we needed to up the dose, or we need to do a lot more to work on them. All right, now, here's the big bombshell. Because when we did a trial, a head-to-head trial with a newer drug, pasiriotide, and we did one of the largest, or the largest, randomized controlled trials in acromegaly with 358 patients in a multinational, multi-center clinical trial, randomized prospective use of pasiriotide versus octreotide LAR in patients who were either post-surgical or de novo treatment. What's the response rate that we got? We got 19%. And we got 19% for octreotide LAR, and we only got about 30% overall for patients with pasiriotide LAR, the better drug. And that one is not matching up to our experience of 50 to 60%. And this actually, I think, really shook all of us in terms of, well, what do we really know? And so one of the things that I did after this was I basically did the same kind of thing that Dr. Freda did, but more than just looking at the response rates of the somatostatin receptor ligands. There were a lot more studies to go through. But I also broke down, like, okay, what were some of the things that led to a better response rate than others? Was it pre-selection, or was it something else? And actually, the only thing that really stood out to me was the duration of the trial. So the longer the trial, the better control you got. There wasn't as much of a signal in terms of multi-center or single-center, retrospective, prospective, the drug, or pre-selectiveness that gave you a higher degree of efficacy. There were some things that have been used, like high dose and increased frequency, and there are some data that show that by upping the dose beyond what our standard doses does give you a little bit more efficacy. But I landed on 55%, basically average IGF-1 and growth hormone control, again with a retrospective analysis of all the clinical trials that have been done with more than 10 patients. And now here, I'm going to transition to our consensus guidelines for acromegaly management. And this was, and I love this because they go to all these places. So Monte Carlo in 2000. And here we have sort of this treatment protocol. And what I want to call your attention to is way down here at the bottom, the growth hormone receptor antagonist pegvisomant. So they incorporated this in 2000. It was recently approved. There was a publication in the New England Journal we'll go through in just a second. And they placed this down at the bottom for patients who had not responded to these others. Now, was this because of clinical trial design? No, because the pegvisomant pivotal trials were all de novo patients that were not treated with somatostatin receptor ligands before. So it wasn't something that was written into the FDA's review of their clinical trials. But it was really placed, and I don't know exactly why, it was really placed as a secondary agent for patients who were not controlled. And there clearly are patients who would benefit from it as a first-line use. And come back to that first diagram that I showed you, where somatostatin receptor ligands, dopamine agonists, and pegvisomant are all on that same level. Again, lots of things go into how we think about which drug to use. This is the pivotal trial. This shows the dose related response to IGF-1, and here again, percent of efficacy. We see above 80% response rate with 20 milligrams. I believe the actual data came to above 90% for patients when titration was used and patients were adequately treated for a longer period of time. We see, however, in long-term studies, we aren't reaching that 90 to 95% response rate with pegvisomant. And it may be because now that it's approved and it's sort of out in use, we aren't titrating that medication up like we do in a clinical trial. But it's not quite matching. It's getting to about 75% now, but it's not quite matching the clinical trial experience. One of the more controversial things about pegvisomant was our concern regarding tumor growth, because pegvisomant does not do anything to control the tumor size. And in many cases, we're taking patients off of a medication, a somatostatin receptor ligand that has tumor control, and putting them on pegvisomant. So there was a lot of concern regarding tumor enlargement in the face of pegvisomant. That has since borne out to not be as big of a concern, but certainly something that we need to watch. And so you do need to monitor patients with MRI. And we'll come back to sort of how we monitor patients toward the end of the talk here. One of the things that I think was somewhat controversial, because it wasn't something that could be talked about in sort of sanctioned areas. Like, you had representatives from companies coming to talk to you about pegvisomant, you had representatives coming to talk to you about somatostatin receptor ligands, but they couldn't talk about combined therapy because it was not FDA approved as a combined therapy. I never quite understood this. We use drugs in combination all the time. We don't ask for the FDA's permission. But this was a combination that was basically proscripted from discussions among people who were treating patients with acromegaly. Of course, in academic centers and in academic circles, we could go to meetings, we could talk about combined therapy all the time. And there were publications coming out of Europe about combined therapy with somatostatin receptor ligands and pegvisomant that showed that it was a highly effective approach at taking care of patients. You got the high response rate with the pegvisomant matched with the tumor control of the somatostatin receptor ligands. But this is a controversial aspect of our care because all of a sudden you're taking two medications that are both extremely expensive and sort of onerous to the patient in terms of their injections and the burden of taking this medication to the patient. And we're saying, okay, this is the best way that we think to treat these patients. We get the highest efficacy rate from this. And what about cost? This study was a study I participated in at Cedars, where we looked at what was the actual cost, and were there advantages to different regimens within the construct of a combined therapy. And we randomized people depending on what they were taking beforehand in terms of did they need more of the octreotide or lanreotide to get their disease control. We stratified them and then randomized them to arms of high dose with weekly pegvisomant, low dose with weekly pegvisomant, or low dose and daily pegvisomant. And we aimed to control everybody. So we titrated everybody up until the point where we got disease control. And what we were looking for is how much did it cost for us to get there? And what we saw in this study was that the thing that ended up being most cost effective was an approach of low dose somatostatin receptor ligand. So basically you take the lowest dose available to you within that class of drug, lanreotide or octreotide, and you add a weekly shot of pegvisomant. And that low dose response still got you to a high degree of efficacy in terms of disease control, and was the cheapest way with the combined therapy in order to get that. And here we see control rates in the three arms, arm B, arm A, arm B, arm C. And like I said, You can look at the paper in terms of the overall cost. We had to do average wholesale prices and things like that that don't match up to actual clinical experience, because what it costs the patient totally changes when it comes down to insurance coverage and things like that. But in terms of the overall cost, we found that the low dose approach was the best. All right, now we'll transition here to comorbidity management and long-term care. Now, I didn't include everything that we could in terms of comorbidities. There are a lot of controversies involving comorbidities. One thing that I was thinking about putting in, and I didn't for the sake of time, is vertebral fractures. And actually, before I go to the next slide, I'll just talk a little bit about vertebral fractures, because it is striking to remember when the publications for vertebral fractures in acromegaly first came out, we were so surprised, because I mean, they're exposed to growth hormone, their bones thicken. How could they possibly be at a higher risk for vertebral fractures? And I remember just sort of it was Ed Laws, who was like, I see so many patients with acromegaly, and none of them have vertebral fractures. Well, if you don't look, you don't find it. And Dr. Giustina in Italy was the one that published this first to show that there were a high amount of vertebral fractures, despite the fact that DEXA scans showed that they had normal bone mineral density. So a tough thing, a clinical dilemma, and some controversy, because it's just kind of hard to believe, but certainly something that's out there. Let's first talk a little bit about surveillance. So there are a lot of strategies for acromegaly surveillance. I think we've sort of evolved over time to doing less. I like doing less as I see my patients. If there's a reason to do one less MRI in a patient, I love it. It's kind of one of those things where if I've got disease control, do I really need that MRI for my decision making? And so we've looked at things like the optimal timing of postoperative disease assessment, and there have been good studies that show that, okay, you may need to wait a little bit for the IGF-1. 3 months might be a good time frame that predicts what's going to happen in a year. So we know that stuff, but we really haven't had a lot of robust data that show us what is the best strategy. Do we need to employ an OGTT? Do we really need to look for that discordance? And there hasn't been, again, a consensus on what we really need to do in terms of our long-term strategies. The other thing that really makes this challenging is because when we start treating patients with medications, our use of our standard tools then don't apply to the patients who are just purely post-operative. And so we have different categories of people that we need to think about in terms of how we're monitoring them. I still believe that IGF-1 is a very valid test for disease activity. And so that is my sort of benchmark. That's the thing that I stand by. And I do perform OGTCs with equivocal use, but equivocal values of IGF-1. The duration and the necessity of repeating those things year after year, like I said, I like doing less. So the less I can do as I follow patients forward, I'm not repeating OGTs every year. Being somebody that likes data, sure, I'd love to do that. In every patient, I'd love to get echoes and all kinds of things on my patients, but I don't. I also sort of am sympathetic to the burden of this disease and the burden of surveillance, and so I try to strike a balance with all of that. Regarding MRI imaging, I think we are at a point where we can start imaging our hormonally active patients less when there is hormonal control. And there are papers out there that emphasize this, but this is not something that most centers have adopted and taken as something that they can count on. But hormonal control, I think, is the thing that really helps us with decision making regarding these patients, not so much the MRI. When we do have patients with, that last point I think is an important one, when we have patients who are on pegvisomant monotherapy, those patients do have a low risk of residual enlargement, but you do need to figure out how often and when you're going to be testing that patient for their MRI. If you want to just wait and do visual fields, that might be sort of a way to do things without doing an MRI, but it's probably prudent every once in a while to get an MRI. Maybe not every year though, you know. All right, last point here is the cause of mortality. And this is a controversial aspect. We touched upon it yesterday, that high IGF-1, high growth hormone, implies a risk of cancer. And probably more importantly, uncontrolled acromegaly leads to a more aggressive course of a cancer that exists. So disease control, I think, really helps with those patients who do have cancers, but we don't really have the clear link between high IGF-1 or high growth hormone and the cause of cancer. It may be because of the long-term exposure of growth hormone and IGF-1. It may be that patients with acromegaly have some of the comorbidities of metabolic disease that we know are also associated with high prevalence of cancers. Things like diabetes, obesity, hypertension. Those things have been linked to a higher risk for cancer. So is that why these patients with acromegaly have higher rates of cancer? We know that in patients where we've done observational studies, sometimes we see higher risk rates of colorectal. There's even studies of thyroid and breast cancer, but they're not consistently demonstrated. And like I said, they can be attributable to variable causes, direct and indirect, and we don't really know the nature of why there may be a high risk. We know that especially in colon cancer, that we have a lot of conflicting data. And we know that in population-based studies, there are some that show an increased incidence, but not in all studies. And even the case control studies are variable, with some showing a very high odds ratio versus no increase in a couple of other studies. What we do know is that polyps are very common in patients with acromegaly. And so it really stands to reason that we need to be screening these patients for colorectal cancer. We need to remove the polyps when we see them, and we need to adopt a plan of surveillance in those patients who do have polyps that aligns with what we do for everybody else with polyps. And in patients who don't have disease control, we may want to be a little bit more aggressive about our surveillance with polyps and colon cancer in those patients. So just having some flexibility in how we approach things, I think, is the best way to go about this. So some concluding remarks. There are several things that have been controversies over the years in terms of our care of patients with acromegaly. Some that have fostered great discussions and a lot of evolution of thought in terms of how we now take care of patients, and some things that persist where we're still dealing with controversies and with some clinical dilemmas. We have some ongoing challenges. I think diagnostic criteria will always be a problem as long as there are things that contribute to assay variation, and that's going to be something that we're going to have to deal with. As right now, we may have better assays, but there's been no real consistent proving that a current assay at a Quest or a LabCorp is better than any of the older assays. I personally have my own experience with things, and I know where I'd like for my patients to go and get their IGF-1 measured, but that may be different from place to place. I think that one of the significant controversies for us is our access to care, our surgical and medical expertise, and costs of care. It would be outstanding if we could channel everybody to an excellent center, to a center of excellence and with neurosurgery expertise. That may not be possible, but we need to navigate that, and we need to really, for our patients, be able to champion that idea that patients really deserve to be seen at pituitary centers of excellence. Nothing frustrates me more than seeing a patient who gets redirected to a surgeon who does not have the surgical expertise to care for that patient. I think that we need to recognize and care for these comorbidities, and as we learn more about the disease, we're learning more about how we need to be vigilant and surveil some of these things. And then also thinking about our role of more aggressive approaches. And this is at the margins. We know how to take care of probably about 90% of our patients with acromegaly. It's the real resistant patients, the challenging cases, the aggressive cases that we have very little data to go on. I think that one of the things that we will focus on in the next decade will be the impact of the disease and its care on the quality of life. And with the advent of newer technologies, newer medications, and maybe add some things that are available that we can't even really conceive of now, there will be an improvement in quality of life. So I'll end there. I want to thank everybody for your attention.
I'm Jorge Fascinetti, Pituitary World News co-founder. I want to take this time to thank you for watching this educational program exclusively produced by Pituitary World News. We are also deeply grateful for your support. To donate and continue to be a part of our mission, please visit us at pituitaryworldnews.org.